I request all those who are standing to kindly be seated. We are about to begin. I request Dr. Shija, President GPA Cochin, and Dr. Girija, Secretary GPA Cochin, to kindly come up on stage. Treasurer is unwell and therefore will not be joining us. I request all the panelists and speakers to kindly occupy the front rows. Requesting the Secretary to invest the collar on the President. Stand for a silent prayer. Thank you. Please be seated. I now call upon Dr. Shija, President GPA Cochin, for the presidential and welcome address.
സാറാണ്. സാറിനെ ഈ വേദിയിലേക്ക് സ്വാഗതം ചെയ്യുന്നു. പാനൽ ഡിസ്കഷന് ശേഷം നമുക്കൊരു ടോക്ക് ഉണ്ട്. മെഡിക്കൽ ട്രസ്റ്റ് ഹോസ്പിറ്റലിലെ കൺസൾട്ടന്റ് എപ്പിലെപ്സി ആൻഡ് ഫങ്ഷണൽ ന്യൂറോ സർജൻ ഡോക്ടർ നിഹാൽ അഹമ്മദാണ് ആ ടോക്ക് നയിക്കുന്നത്. ആ സാറിനെയും ഈ വേദിയിലേക്ക് സ്വാഗതം ചെയ്യുന്നു. ഈ ഒരു CME ഇവിടെ അറേഞ്ച് ചെയ്യാൻ നമ്മളെ സഹായിച്ച നമ്മുടെ തന്നെ മെമ്പറായ ഡോക്ടർ മരിയ വർഗീസിന് ഒരു പ്രത്യേക നന്ദി അറിയിക്കുന്നു. അതുപോലെ എല്ലാ GPA അംഗങ്ങളെയും ഈ മീറ്റിംഗിലേക്ക് സ്വാഗതം ചെയ്യുന്നു.
Thank you, Dr. Sheeja. Now it's over to Dr. Girija for the report.
Good evening to all. The GPA CME program for May unfolded on the evening of May 28, 2024 at the esteemed IMA Hall in Kochi. Commencing at 8 p.m., the event commenced with the investiture of Dr. Marman as the President, a moment marked by Dr. Philip John, the Secretary. In his inaugural address, Dr. Marman underscored the pivotal role of women leaders within GPA for the upcoming term 24-25. Following this, Secretary Dr. Philip John delivered the comprehensive annual report for the year 23-24, encapsulating the achievements and endeavors of the preceding tenure. Dr. Shanda Irali then introduced the esteemed speaker, Dr. Shweta Shivai, who delved into the contemporary subject of vertigo and its management, then sparking engaging discussion that continued until 8:20 p.m. The president of the meeting, Dr. Marman, invited the newly elected office bearers, Dr. Sheeja Srinivas, Dr. Girija, and Dr. Indulekha Latika, onto the stage. Subsequently, the spotlight shifted to the installation of the new office bearers, a ceremonial affair graced by the presence of dignitaries, including Dr. Hanish, President of IMA, Dr. Abraham Verghese, Installation Officer, and Dr. John Pulan, Secretary IMA, alongside Dr. Mary Simon, Chairperson of IMA. The ceremony commenced with a prayer led by Dr. Rosalie Devi. The meeting paid homage to the departed IMA doctors of the preceding year, 2023-24. Secretary Dr. Philip John then extended a warm welcome to the assembly, followed by the presidential address delivered by Dr. Marman. The installation officer, Dr. Abraham Verghese, offered a succinct history of the General Practitioners Association, setting the stage for the installation of the new office bearers. Dr. Abraham Verghese installed the new president, Dr. Sheeja Srinivas, and read out the oath where the newly elected president formally pledged to uphold the responsibilities and duties of the position. The president then introduced the new team members, Dr. S. Girija, Secretary, Dr. Indulekha Latika, Treasurer, and Dr. Derina Mendes, Joint Secretary to the forum. The ceremony started with the lighting of the lamp by all the dignitaries on the stage. Dr. Sheeja Srinivas shared insight from her journey in GPA, followed by an inspiring address from Dr. Hanish, President of IMA, Kochi, who formally inaugurated the activities of GPA for the term 2024-2025. Dr. Mary Simon and Dr. George Thulan, in their facilitation speeches, stirred the audience with their words of wisdom and encouragement. The event culminated at 9:50 p.m. with a gracious vote of thanks delivered by Dr. Girija, the newly elected Secretary of GPA, marking the beginning of a promising chapter for the organization. Thank you.
Thank you, Dr. Girija, for that very comprehensive and articulate report. So I think without any delay, we'll go on to the CME program. And yeah.
Now handing over the mic.
Let me start off by quoting John Patton itself. He says, "The exact anatomy and physiology of micturition is still not well understood, and hence the mechanisms of micturition disturbances in disease remain rather speculative." So why am I starting with John Patton? Because I remember during my MD days in St. John's, if you had to ask a postgraduate the most toughest of questions, it always had to deal with micturition. And I, even as a postgraduate trainer myself, for my DNB students who are there with us for their DNB in medicine and family medicine, it is always the most toughest topic to give. In fact, the joke amongst us was, my PGs are going to suffer now because I have revised this topic now for the talk as such. But I'll put you at ease. What we are trying to do today is basically trying to master at the level of a GP and a basic specialist, who I'm sure all of you will be seeing much more cases than all of us who are at Medical Trust on a day-to-day basis about elderly lower urinary tract symptoms. We're going to look at these basically in a very, very simplified manner. We are not going to give you this bombardment of John Patton, neurophysiology, anatomy, and all that. We're just going to give you case scenarios. And these are day-to-day cases. We're not going to confuse you any further. We'll try and demystify what is a difficult management issue called incontinence. I was very glad to hear the secretary speak in very simple Malayalam. So my first story is a personal story. ഈ അടുത്ത് എൻ്റെ വളരെ അടുത്ത ഒരു അപ്പച്ചൻ ഹോസ്പിറ്റലിൽ വന്നു കഴിഞ്ഞ് അദ്ദേഹത്തിൻ്റെ കൊച്ചുമകളെ, സർജറി കഴിഞ്ഞ് കിടക്കുന്ന കൊച്ചുമകളെ കാണാനായിട്ട് എൻ്റെ അടുത്ത് പെർമിഷൻ മേടിക്കാനായിട്ട് വന്നു. അപ്പം മെഡിക്കൽ ടെസ്റ്റിൽ കയറുക എന്ന് പറഞ്ഞത് നിങ്ങൾക്ക് അറിയാമല്ലോ, അത്ര എളുപ്പമുള്ള കാര്യമല്ല. എസ്പെഷ്യലി ഇൻ പേഷ്യൻസ് പാസ് എടുക്കണം, ആരെങ്കിലും പെർമിഷൻ വിളിച്ച് പറയണം, PR കൂട്ടി വിടണം. അപ്പോൾ വന്ന സമയത്ത് എൻ്റെ OP യിൽ വന്നിട്ട് പറഞ്ഞു, സാറേ എനിക്കിന്ന് അവളെ കാണാൻ പറ്റിയില്ല, സാർ റൗണ്ട്സ് എടുക്കുമ്പം അവളോട് പറയണം എനിക്ക് കാണാൻ അല്പം ബുദ്ധിമുട്ടുണ്ട്. അപ്പം ഞാൻ പറഞ്ഞു, കൊച്ചു ചോദിച്ചല്ലോ, അപ്പം എനിക്കൊരു കുറച്ച് ബുദ്ധിമുട്ടുണ്ട് സാറേ, ഐ എം വെറ്റ്. So he is a distinguished chartered accountant, 81-year-old. He was rushing from his estate in the heavy rains just to see her. But by the time he reached the hospital, he was completely wet and he couldn't get into the hospital. So just imagine the plight and the mental agony of that patient from the perspective of that patient alone. So that just puts things in clear perspective about how difficult, how disturbing and often mentally and socially embarrassing for people who go through this, something which we classically call as incontinent. നമ്മൾ പണ്ട് തമാശയ്ക്ക് പറയും പേടിച്ച് മുള്ളി അല്ലേ. അപ്പം it is not as simple as that. As we grow old, this is probably an area which we have to focus our efforts on. To try and demystify this, we will take you through the cases. We have amongst us expert panelists, 2 expert urologists, we have a geriatrician, and we will look at the breakthroughs in the final session, which is going to be taken by our neurosurgeon regarding what are the cutting edge things which are available in case you want to refer patients for that thing. So without further delay, I'll get on to the first case. So the first case is of a case of a stream interrupted, and the case is like this. Here is Mr. John Stephen. Please don't worry, these are hypothetical cases and I'm not quoting anybody by name, just so that we familiarize ourselves with names alone. 78-year-old man who's a type 2 diabetic, who has a history of benign prostatic hyperplasia, documented to have hypertension, and symptoms which start with difficulty in starting urination, a very weak urine stream, frequent urinations at night, constant dribbling of urine, and a feeling of incomplete bladder empty. So you will document that these are mostly lower urinary tract symptoms. And at present, if you want the medication history of this patient, Mr. John is on metformin, tamsulosin, and he is on losartan. So I'll direct the question to Dr. Sachin first. Dr. Sachin, as a urologist, I want to ask you, what is the basic diagnosis and pathophysiology of benign prostatic hyperplasia? Why is it so important to understand how it leads to incontinence? Because it's basically an obstructive disease, right? How does it lead to incontinence in an elderly person?
So, good evening, sirs and madams. So basically, this is supposed to be a case of obstructive voiding symptoms. Like when you say about lower urinary tract symptoms, in urology, grossly we can classify it into an obstructive symptoms as well as storage symptoms. So obstructive symptoms means something related to the obstruction by any of the causes like prostate or some obstruction at any level of the urethra, mean bladder outlet. So the other one is the storage symptoms, which are secondary to bladder irritation, or the bladder overactivity secondary to higher higher center disorders. So reading at the symptoms, here we see difficulty in starting urination, weak urine stream, and then comes, so these two are basically the obstructive means lower urinary tract symptoms, and then comes the frequent urination at night, then constant dribbling of urine and feeling of incomplete bladder emptying. So basically in prostatomegaly, what happens is there is a median lobe that and the lateral lobes. Prostate has got the lateral as well as the median lobes. These lobes enlarge, they bring in some compression of the urethra and produce outlet obstruction. So it starts with obstructive symptoms or the voiding symptoms, and as it enlarges, when there is a median lobe, it enlarges and presses onto the trigone. The trigone gets irritated, and gradually the irritative symptoms come in. For in some people, maybe the irritative symptoms, maybe the storage symptoms may be the beginning, because the lateral lobes are not that enlarged. It's a median lobe that is enlarging into the, pressing into the trigone, and that produces the storage symptoms. That is frequency, urgency, and nocturia. These are the three classical storage symptoms. Whereas the obstructive symptoms, poor stream, intermittency, straining, and the feeling of incomplete evacuation. These are the four classical obstructive symptoms. So this 78-year-old man is coming with obstructive symptoms and dribbling of urine. So in this scenario, we have to consider the most commonest possibility, that is BPH. Then in urology, we have to think about other possibilities as well. Like, for example, it could be a carcinoma prostate, which has got infiltrated into the trigone, producing these storage symptoms. Again, it could be prostate producing symptoms along with some residual urine that acts as a nidus for infection, and this infection is producing this storage symptom. So it could be infection secondary to BPH, it could be carcinoma prostate. Again, in urology, within urology, you have to think about BPH along with another pathology, maybe in the bladder, like CF carcinoma bladder, that is infiltrating the detrusor and producing storage symptoms. So these are the different possibilities. When you different possibilities we consider from the urology perspective. Again, there could be a BPH along with some neurological problems.
Points taken, Dr. Sachin.
Yeah.
What are the key diagnostic tests that you would want in this patient to help you differentiate the DDs?
So basically, we have these differential diagnosis. First, we have to differentiate between these possibilities. We have to go for a urine microscopy, urine culture, go for a serum PSA, ultrasound abdomen. These are the basic investigations to be done: urine examination, PSA, and ultrasound. So with which we can differentiate between whether it is infection, whether it is any possibility of malignancy like CA prostate, or whether it is whether there is a possibility of a bladder cancer, a bladder lesion happening there. The basic screening helps in differentiating these three. Again, in ultrasound, you can look for the residual urine also, post-void residual urine also. So up to 50, we consider it as normal. More than 50, it is abnormal. So we have to address it. Anything more than 200, it is very, very, very significant. We have to seriously consider that.
And having got these tests, I would like to ask you, what are the first line pharmacological treatments for managing incontinence generally in a BPH? And if this is the current medications, would you want to modify these, and why?
Yeah, in this scenario, this gentleman, 78-year-old man, he is coming with obstructive symptoms and storage symptoms. So you have to so regarding the storage symptoms, it could be an overflow incontinence, it could be irritative, an irritative reason that is producing the dribbling of, the dribbling of urine and incontinence. So we have to differentiate between these two because the management is entirely different. So the key point would be to look for the residual urine when after voiding, there's a significant amount of urine staying back. You have to take it as an overflow incontinence that is happening secondary to chronic retention and detrusor hypoactivity. Otherwise, it has to be managed the other way. Like if the post-void residue is less, you have to think about other possibilities. So you have to make a line between these two possibilities. So if it is a case of overflow incontinence, the next step is to go for a catheterization and give rest for the detrusor. If it is otherwise, you go for, if the residual urine is not very significant, you can go for bladder sedatives. Like in bladder sedatives, we have two groups. One is the antimuscarinics, anticholinergics, and the other one is beta-3 agonist. So you can consider a combination or individual these two group of drugs. Again, if it is because of an obstructive cause, you have to consider starting alpha blockers as well.
Okay. Now, if this is the setting, what are the conditions in which you would think of a surgical option for him? And if the surgery is advised, how would you counsel him about the surgical options which are available right now?
So basically, in any retention, surgery is not the first line of treatment. Basically, it is a medical therapy. We consider the alpha blockers along with the combination of finasteride or dutasteride. And if there is a steroid symptom, you have to consider adding the anticholinergic or the beta-3 agonist like mirabagrone. If that doesn't work, then we may have to consider surgical options. So generally, the surgical options are considered in a case of BPH in the following situations. One, it's a refractory urinary retention, like 2 or more episodes of urinary retention which happens in spite of medical therapy. 2, there is recurrent episodes of hematuria, like patient is keeping on coming with episodes of hematuria in spite of being on treatment with finasteride or dutasteride. 3rd, repeated episodes of infection, urinary tract infections. You treat the patient with antibiotic, you stop the antibiotic, he comes back with infection. So that is again an indication for surgical management. The patient is on medical therapy. In addition to that, antibiotic is being given. Once you stop the antibiotic, patient comes back with infections. So that is another indication for surgery. 4th is there is a BPH with evolving changes within the system, like the patient develops bladder diverticulae, or the patient bladder pressure increases and there is a pop-off mechanism happening at the vesico-ureteric junction resulting in bilateral hydroureteronephrosis. There is development of bladder stones, and there is it reaches a situation where the patient comes with obstructive uropathy and renal failure. So if you have hydroureteronephrosis with prostatomegaly, BPH, if there is renal failure secondary to this, these events, if the patient develops bladder stones secondary to prostate, if there is repeated episode of urinary tract infection secondary to prostate, if there is repeated episode of hematuria, or if there is refractory urinary retention, these are the indications for surgical therapy. Again, if all the medical therapy you are giving, these are not happening, but patient is not happy, patient is not tolerating the medications, or patient is not happy with the response with the drug, there are situations where when there is enlarged median lobe, the median lobe bulges into the bladder and it produces a ball valve mechanism, in which case most of these alpha blockers may not work. So these are some situations, like you give the medical therapy but patient is not responding, patient is not happy with his symptoms. Again, that is another indication for surgical therapy.
What are the surgical options that you routinely employ, and what are the newer modalities in surgery now?
So the conventional one is the TURP. Again, that is, you use the electrocautery as the energy source. You resect the enlarged lobes, the median lobe or the lateral lobe, and create the channel. Now, the other modality is using laser, HOLEP, holmium laser enucleation of prostate, where you enucleate the prostate and then like the lobe is enucleated and pushed into the bladder, and then we morcellate and take it out as the bits, as tips. So that is another option for this thing, the BPH treatment. Again, when the patient is old with a lot of comorbidities, when he cannot undergo an anesthesia, he cannot take up the risk for this TURP or a HOLEP, then we have the option of prostatic artery embolization. And I would like to make it clear, when you compare the results of the surgical option versus the prosthetic artery embolization. Prosthetic artery embolization stands much, much inferior with regard to the flow rate, with regard to the results of any of these surgical options. So basically, it is being advised for people who cannot undergo the procedure. The advantage of embolization is it's generally being done as a decade procedure. It's a very non-invasive thing, but the results are, the results are not equivalent. It's very much inferior to the surgical options. So we always consider that as an option where the patient cannot undergo this surgical therapy.
What about the other techniques that are in vogue now?
Yeah, we have now the newer techniques. So one is the Eurolift. So Eurolift, it is basically, it's an endoscopic technique where using the endoscope, you have the Eurolift probe, you advance it into the prosthetic urethra, and then you can fire, you can deploy this, what do you say? You have, it's basically the concept is to retract the lobes of the prostate, so the lateral lobes and the medial lobes. But mind you, it's basically more effective for the lateral lobes more than the median lobe. And the once you fire it, it has got three parts. One is a PTE string, and towards the outer part there is a nitinol part, and the inner side there is the stainless steel part. So these two, between the wire on either side there are two metallic things. So basically the lobe is getting retracted laterally, and the lateral lobes are being retracted laterally, and the channel is opened. So its advantage is, one, it is being done as an OP procedure. Two, the chances of sexual dysfunction, it is much, much lesser when compared to the TURP or the HOLEP. So it is being, it can be considered for younger people who are undergoing procedures for BPH. The problem is, this is a newer modality. It was started some 7 years back. So we have the results of the last 7 years, but we don't know what the long-term longevity of the effect of this technique. So we have to wait and watch. But still, 7 years, it's doing fine. So the success rate is around 80-85%, very much comparable to the conventional surgery as well as the laser surgery. So again, the newer modality, next one is Resume, where it's again an endoscopic procedure, where using the endoscope, you identify the lobes, and then you have the firing gun. It's not firing, it's a gun through which you instill water vapor into the gland and bring about coagulation of the enlarged tissue, and this results in coagulation necrosis over a time. It takes maybe 4 to 8 weeks. So basically you do the procedure and send the patient home, and the results the results happen maybe 1 to 2 months later. So a patient without catheter, he may have to be on catheter for some time, maybe 2 to 4 weeks. Whereas a patient who is already on catheter, he may have to be on catheter for maybe 3 months. Maybe in a month, we can give a trial. It can go up to 3 months. The advantage is you don't need an anesthesia. It can be done as a day procedure. So with patients with a lot of comorbidities, you can consider this as an option. Again, the sexual dysfunction is also comparatively lesser. Yeah, this is basically the Resume.
Okay, thank you, Dr. Sachin, for the elaborate discussion on the first case. So now I go into the second case, which is breaking the dam. We're going to discuss a female incontinence now, elderly woman with stress urinary incontinence. As you all know, women have much more chances of a urinary incontinence. So this lady, Mary Kuti Sebastian, she's a 72-year-old lady, is obese. She has a history of multiple vaginal deliveries, mild osteoarthritis, and she has a history of hypertension. She gives a history of leakage of urine during coughing, sneezing, or physical exertion, and occasional urgency is noted without leakage. Her current medication, she's on acetaminophen for osteoarthritis, she's on N-Lapril, calcium, and vitamin D. So with that, I would like to ask Dr. Thomas a few basic questions. What anatomical changes are we looking at which typically lead to stress urinary incontinence being much more common in our elderly women?
In most of the ladies in the postmenopausal period, the pelvic musculature becomes very weak, and as a result of multiple deliveries, previous history of any pelvic surgeries like hysterectomy or so, the muscles become weaker, and this leads to the descent of the urethra across the pelvic musculature, and this leads to stress urinary incontinence. There are three main mechanisms depicted. One is the intrinsic sphincter deficiency. With aging, almost all the patients will have decrease in the sphincter continence. And also, then next is the urethral hypermobility theory, in which the urethra become hypermobile, and as a result, the urethra descends across the bladder neck, descends across the pelvic musculature, leading to urinary incontinence. Okay.
Would you advise any specific tests or examinations for diagnosing such stress urinary incontinence in these patients?
First of all, we have to do a clinical examination to rule out any pelvic organ prolapse. Then we have to do the specific tests like Q-tip test and the Boney's test. In Boney's test, we have to demonstrate the stress urinary incontinence. The patient is lying in the supine position with the legs lithotomy position, and ask the patient to cough. And if the patient leaks, then we have to put 2 fingers inside the vagina and lift the urethra from either sides and ask the patient to cough again. And if she doesn't leak, that's Boney's test positive. And it is due to urethral hypermobility, and it can be corrected by surgery or medications.
Now, I'm sure you will also be hesitant to take up this patient who has multiple comorbidities for a surgical procedure. So, what are the most effective non-surgical treatment options for stress incontinence?
First of all, we should advise all the patients that their pelvic muscles are weaker, and they have to tone up the pelvic muscles so that they can regain the continence. First, the patient should be motivated towards the pelvic muscle training. That's the Kegel's exercise. That all the after the delivery also, most of the ladies are taught to exercise their pelvic muscles to avoid prolapse and other incontinence. So the pelvic muscle training is the first step for regaining the continence. Along with that, we have to give other advice that the biofeedback mechanism also, in which the patient can be instructed to put, there are certain vaginal cones which are of different weights, and the patient standing in the erect posture, they have to put a vaginal cone inside the vagina above the level of the levator muscles, and they have to hold the cone for at least 15 to 20 minutes. These all will strengthen the pelvic muscles, and a few people can regain their continence. Minimal leakage can be regained by the continence can be regained by this method.
Now, how effective have you found these pelvic floor muscle trainings in these cases?
That should be the first step, and it has the people with minimal incontinence can regain their continence with just pelvic muscle training. And the people should be taught which is the pelvic muscles and how to tone them up. When the patient is an elderly lady, the pelvic muscles are lax, and it has to be toned up so that they can regain the continence.
Okay. So beyond pelvic floor exercise training, when would you take up these patients for surgical options, and what are the surgical options that you're looking at?
First of all, we should add the patient on medical management also. The SSRI inhibitors, selective serotonin and noradrenaline reuptake inhibitors like duloxetine is the drug of choice for basically stress urinary incontinence. The mechanism is that it increases the pudendal nerve supply from the spinal cord and increase the tone of the external sphincter. So duloxetine should be started at a dose of 20 or 30 milligram as per the patient tolerating. If the patient is tolerating, and they get, most of them will get a benefit of the stress urinary incontinence on starting duloxetine. And coming to the surgical management, we give a try of the medical management for at least 2 to 3 months. And if the patient is comfortable with that, we can continue the medication for at least 6 months. But if a few people who are not continent, even on medications like duloxetine, we have to step them up to the surgical management.
Or is there a role for estrogen creams in such patients?
Definitely. The estrogen cream, most of the postmenopausal people will have vaginal atrophy, as a part of which these estrogen receptors are available inside the bladder and also the urethra. So the bladder, the involuntary contractions of the bladder can be decreased by the estrogen cream, and the blood supply of the urethral submucosal plexus of vein can be increased by the estrogen cream. These all will increase the continence mechanism. Coming to the surgical option, the most commonly we use the midurethral sling mechanism. It's a tension-free vaginal tape which is used with which is used to regain the continence. In the patient, the lithotomy position, we make a small incision on the anterior vaginal wall, just around 2 centimeters proximal to the urethral opening, and we place a polypropylene mesh with a helical passer, which is anchored onto the obturator membrane. So this is a daycare procedure, and the patient gets much benefit out of this. Other surgical options is a laparoscopic Birch corpus suspension. This is when few patients who have got the urethral hypermobility. This is a laparoscopic technique in which we created retropubic space laparoscopically and put 2 to 3 sutures on either side of the urethra, then fixing the anterior vaginal wall and the peripelvic fascia, perivesical fascia onto the iliopectineal line. These are the 2 surgical options which are commonly used for stress urinary incontinence.
Thank you, Dr. Thomas. Now I come to the third case, which is urgent matters. So here is Mr. Radhakrishnan P. He's a 75-year-old gentleman who gives you a history of a cerebrovascular accident. He has cognitive impairment, congestive heart failure, hypertension and diabetes. There is symptoms suggestive of sudden and intense urge to urinate followed by involuntary leakage, frequent urination, and he also has nocturia. Like most geriatric population who comes across to your OPD, always have a look at an audit of their present medications, and he's on very commonly used medications, amlodipine, donepezil, he's on furosemide probably for the heart failure, and he's on ecosprin, he's on clopidogrel, atorvastatin because of probably the statin, the CVA that he's had. He's also on the anti-diabetic medications, metformin, glycoside, multivitamins, he's on lorazepam, and he's on pregabalin. So my questions are to the geriatrician in the panel today. Dr. Gino, can you tell me how you will diagnose and look at the pathophysiology of incontinence in this patient, and in general, from your comprehensive geriatric assessment, how do you find out what is relevant for these kind of urinary issues in elderly adults who visit your geriatric OPD?
Good evening, everybody. When it comes to geriatrics, almost all these problems are taken as syndromes. So just like you have metabolic syndrome, urinary incontinence is a well-known geriatric syndrome. So it is not just about the incontinence per se what matters. It is all about what all are contributing to it and what all is coming out of it. So like in all these cases which were discussed so far, you can see that there are medical history points which are actually contributing to their incontinence, as well as there are problems which are resulting out of their incontinence. Let's look at Radhakrishnan, for example. Radhakrishnan has a CVA, he has a cognitive impairment, he has a CCF, he has a hypertension, he has a diabetes. At the outset, these all may look at a different set of problems, nothing to do with the problem which we are dealing today in the house. But technically all of this can actually contribute to incontinence in this gentleman. Look at the medicines, amlodipine, donepezil, furosemide, none of these medicines are per se anything which you will see with urology, or none of these medicines are per se any of those medicines which you would think about urine in the straight place, except maybe furosemide. All of us know that furosemide will increase the frequency of micturition. But almost every drug in this list actually contributes to the incontinence and the problem associated with Mr. Radhakrishnan. So in geriatric assessment, whenever a patient comes to our OPD, we have this routine habit of asking them basic questions regarding their activities of daily living, regarding their baseline functional status, what we call as a comprehensive geriatric assessment. In that we ask them about their stool pattern, we ask them whether they have had a fall in the last 1 year. Along with that, every patient gets asked this question in their first visit: have you had any episode of incontinence in the last 1 year? Do you feel the urgency to pass urine? Do you have issues in holding your urine? Do you have issues? Do you feel that speed of your urine is decreased? Do you feel that even after passing urine, there is some amount of residual urine left there? So these questions, I have listed some of these questions here as well. These questions, when answered as yes, it actually warrants, it actually opens the Pandora's box, it actually opens the door of a syndrome called urinary incontinence rather than a specific problem there. So in a regular geriatric interview, I think we should all, whenever we encounter an older person, the habit of asking this question, whether they come to us for diabetes or whether they come to us for hypertension, I think it's prudent to ask whether you have a urinary problem, at least to ask how many times in night you get up to pass urine, and if they answer more than once, that automatically calls for a lower urinary tract symptom, and you need to classify and identify what exactly is going through this patient. So one simple way of tracking, when they say that they have urinary incontinence, one simple way of tracking and seeing what they have is to keep a bladder diary. So we have an image of a bladder diary on the screen. So this is something like, you just need to have time on one side. You need the patient to document what type of drinks they have taken at each of those timing. And the next column, you're going to ask them to measure. For this measurement, obviously you cannot ask them to estimate the urine. You have to ask them to actually buy a measuring can or even a glass or a cup or whatever is measured and quantified. And they have to measure and say that how much of urine was passed after each drink of water or during the entire day. And also there is a question on asking them, how urgent was your symptom? So it's basically a gradient. You have to say, if it was not at all urgent, you can put it as 0. You felt the urgency, you felt that I have to go immediately, but you could hold, you have to put 1. And similarly, if you could not hold and you had to rush to the toilet, you have to put 3, 3 being the maximum. So you grade that there. And the last column would amount for leakage. So if the leakage was the urgency, you put S. Leakage was with an activity like cough, sneezing or jogging or whatever. If they had to run around and they had a leakage, you put it there. You ask for whether they were using diapers. So all this, when you bring it as a comprehensive chart, it is very easy to actually classify and understand their problem. Rather than saying, Doctor, it is much more objective when it is put on paper and when it is shown when you actually leak urine and how you had a problem, because you can even plan your interventions. See, for example, this bladder diary automatically sees that, okay, the patient had the last drink of water at 8:30. So you can say that, okay, you cut down that last glass of water at 200 ml plus that 50 ml of glass of wine which he has taken. Obviously, the wine at late night, though many of us would like to have that, but it's going to give a diuretic effect and it's going to, make him get up in the night again for passing urine. Once you see this chart, it is very easy. It's like bringing a self-glucose monitoring chart to you. Very easy to pick up and say that you stop this habit, your urinary incontinence or your urinary problem in the night is going to get better if you suddenly make a change. So this is important in diagnosis as well as it is important in managing the patient. So this is something which all of us can easily do. You need not have even a printout. You can just ask them to write on a piece of paper these data and bring it to. And many older patients, at least I see, are very much compliant to do such things because they take it as an activity to actually measure their urine and bring it on a paper. So,
Gina, can you also clarify how does a stroke per se contribute to incontinence in the particular case that we discussed?
Yeah. So any stroke, whenever you have an involvement, so it's the urine, though it has a self-regulatory mechanism down there, though it has a sympathetic and parasympathetic activation which can control the bladder there, it has a predominant inhibitory control from the brain. So once you have an insult to the brain, it need not be even a stroke, even if it's a degenerative condition like say an Alzheimer's disease or say a normal pressure hydrocephalus, when your pressure is exerting onto the lateral walls and your bladder fibers are getting compromised, all of this can take away predominantly the inhibitory control of the bladder. So this can actually lead to bladder incontinence, and that's why most of our neurological patients are actually ending up having incontinence as a major issue.
Okay. That is how your dementia patients are also accounted for in the incontinence.
Yeah. Dementia patients also have another component called functional incontinence. We were talking about all the other incontinence. Functional incontinence is when somebody has the capacity to hold the bladder, but a functional limitation is not letting them reach till the toilet. For example, if I had a fracture and I cannot go to the toilet, I am having functional incontinence. If I am demented, I am not thinking myself that I should have the, if I forget the importance of being continent, that also is a functional incontinence. So any CVA patient and a dementia patient can also have not just this neuronal thing, they can also have a functional incontinence component.
Okay, this is what Dr. Jina was trying to clarify at the molecular level. I'm sure Dr. Nihal will tell you in more detail regarding the levels. Now, what I would want you to further clarify is what are the behavioral therapies which are most effective for managing urgent incontinence in your elderly patients?
Yeah, I think what I have listed here, one more thing is, see, to have a continent bladder in elderly, you need to have a effective lower urinary tract function, which I think that's what the urologists in the house were just now telling us. Also, you need to have adequate mobility and dexterity to use the toilet, which is very much, probably that's one of the major reasons in many of our elderly, they're walking with a walker. In the night, they cannot reach the toilet in time when they have an urgency that could give to incontinence. Adequate cognitive function is very much important for recognizing toilet needs. Motivation. There are many older adults, I'm sure all of us encounter in our practice, who say that padding ketti kedannollam njan enne veruthe kashtapeduthanda. I don't want to go to the toilet. So motivation itself is important. And environmental factors. Many of our older people, they are having toilets within their room, but there are people who are living with toilets outside the house, their toilets somewhere far away. I'm sure they'll be having incontinence not because of any other medical problem, probably because of lack of accessibility. Now, coming to the medications, I had just briefed
If you
upon.
have to go through what our gentleman was having and how you would modify it, so that our audience gets an idea of how you modify the regular medications of this particular patient.
Correct. So these are probably the medications which actually affect your continence. Can we go back to the original slide of that Radhakrishnan? So if you look at Radhakrishnan's medicines, Radhakrishnan's amlodipine. Can anybody think how would amlodipine worsen continence? Amlodipine. Amlodipine, potentially, what is the side effect we see with amlodipine? We see pedal edema, overload of fluid. Can definitely, all this fluid which accumulates during the daytime will come back into the system in the night. You will want urgency, you will have increased frequency in the night. So amlodipine straight away, I would want to change that into a better drug, probably a ARB if these other parameters are okay. Donepezil, any cognitive impairment patient will have that. Donepezil also causes urge incontinence. Furosemide, you know that the furosemide will push out, you will try to push out the urine. Most likely during the daytime, it will increase your urgency. More fluid push will definitely lead to a lot of incontinence issues as well. Ecospirin, clopidogrel, thankfully nothing much directly to do with that. Atorvastatin also escapes. Metformin escapes. But having been, the very fact that the patient has diabetes actually pushes the patient to increase frequency of micturition. So that also could be contributing there. Multivitamins may not be problematic. Lorazepam, which is a terrific combination for somebody who has nocturnal incontinence, because as you know that he would be forced to get up in the night to go to the toilet. And the last thing I fear, I don't worry about the incontinence in any patient whom I see. I worry about the fall which comes after the incontinence. My reason to refer to Dr. Sachin or Dr. Thomas would be because I wouldn't want that fall to happen in the night because of their urinary problem. Lorazepam is the worst thing you can do. Pregabalin again causes urge incontinence by promoting fluid overload. And even those conditions itself, CCF itself, you know that the nocturnal frequency of micturition would be higher. So coming back to the drugs again, as we can see in the next slide, most of our routine drugs, most of them actually interferes with our urinary bladder habits. So it'd be prudent to at least keep away some of these things to the daytime. I think in the case which Dr. Thomas discussed, that case also, that patient had a ramipril or enalapril, so it could worsen cough. It could actually precipitate more of stress incontinence. So we need to clearly look at those medicines and plan accordingly.
Would incontinence per se cause increased risk of geriatric issues in your patients?
Yeah, per se, most commonly, starting with urinary tract infection to recurrent falls to reduced self-esteem, which may lead to personality issues, depression and dementia. So it could have a wide variety of geriatric problems which come after incontinence, and the incontinence doesn't end with the urinary tract itself. So the behavioral interventions which we can look at older people, these are some of those things which I think already Dr. Thomas was telling us about, the pelvic floor training. So bladder training and scheduled toileting is something, I think we can go to the next slide. I've summarized it and kept it there. So some of the key strategies to adopt. Point number one, we should ensure that they have good bowel movements. So without good bowel movements, incontinence is a free bonus with constipation. You have constipation, you have to take care of the constipation. Patient is not ambulant. Ensure some way that good physiotherapy is given. They are ambulant. They can walk with a walker or whatever walking aid properly. Schedule toileting. This is a strategy where you actually tell the bystander that prompt the patient every 2 hours or say every 1.5 hours to actually go and visit the toilet whether they feel the need or not. ഒഴിക്കാൻ തോന്നിയാലും തോന്നിയില്ലെങ്കിലും you go to the toilet, മൂത്രം ഒഴിക്കാൻ ശ്രമിക്കുക, whatever little you have, you pass. So with that, you are actually avoiding the chance of incontinence. And double voiding, before you go to sleep. So നമ്മൾ പറയും before you go to sleep 10 മണിക്ക് ഉറങ്ങാൻ പോവാണ്, 10 മണിക്ക് മൂത്രം ഒഴിക്കുന്നവരാണ് എല്ലാവരും. പക്ഷേ ഉറങ്ങാൻ പോകുന്നതിന് മുൻപ് 9 മണിക്കും 9:30ക്കും ഒന്ന് ഒഴിച്ച് ബ്ലാഡർ എം ടി ആക്കിയതിന് ശേഷം പോകാൻ ശ്രമിച്ചു കഴിഞ്ഞാൽ രാത്രിയിലെ ഫ്രീക്വൻസി കുഡ് മാർക്കഡ്ലി റെഡ്യൂസ്. Along with that, if you can restrict your fluid intake after 5 o'clock, സാധാരണ പറയാറുള്ള മരുന്ന് കഴിക്കാനുള്ള ഒരു 1/2 ഗ്ലാസ് വെള്ളം ഒഴിച്ച് വേറെ വെള്ളം കുടിക്കാതിരിക്കുക. And medications, like we saw all those medicines which are coming towards the later half of the night, you can put them. ഒരു കാരണവശാലും ഡയോറിറ്റിക്സ് കൊണ്ട് രാത്രി 8 മണിക്ക് കൊടുത്തിട്ട് you cannot imagine the patient to be not having nocturia. Obviously they will have nocturia. Improvise and adjust. Kapi, chaya, tanni. 3 സാധനം. Tanni in the sense of alcohol. So these are three things, taboos, which should be limited after 5 o'clock. I know many older people, even if they don't want alcohol, many of them have the habit of drinking coffee at night. That will not only impair their incontinence, that will also mess up with their sleep. So all of these things should be restricted before 5 o'clock. And we should specifically ask the family members regarding the functional and environmental barriers. Some of them, even the toilet access within the room, lack of light, lack of switches, lack of somebody to call. ഇതുകൊണ്ട് രാത്രി ഡയപ്പർ ഒട്ടിച്ച് കട്ടിലേക്ക് കിടത്തുന്ന സിനാരിയോ ആണോ എന്നുള്ളത് we have to talk to them and find out. And adequate physiotherapy, not only to strengthen the pelvic muscles but also to strengthen the core muscles, is very important in preventing and helping somebody with incontinence.
Thank you, Dr. Gino. I think we have covered most of these medications through the expert comments from the urologist and Dr. Gino now. With that, I go to the last case. So if you thought this is a problem of only the elderly and there are more issues to handle, especially in a younger patient like this. Here's a younger adult with urinary incontinence, Suhra. She's a 32-year-old lady who's the CEO of an IT company in Infopark, has no significant past medical history at all to contribute to the history taking that we just elaborated in the geriatric cases that we just discussed. But she has symptoms of urgency, that is the increased frequency, and she's struggling to attend her scheduled IT company meetings because of the incontinence and the social issues associated. She's not on any current medications. So that I'll just go quickly across to Dr. Sachin now. Sachin, how difficult is it to manage a younger adult with none of the classical associations that we just dealt with in the previous 3 cases?
So here the history is like frequency, urgency, which is impairing the daily activity of the person. And what we have to look at is what is the duration of these symptoms. Like acute onset, the most common possibility in a young person is the usual urinary tract infection. You have to rule out that. So the most commonest scenario what we come across is a urinary tract infection. So you evaluate for that. The urine test is fine. There is no evidence of infection. You look for any other pathologies. Let's say, as I had discussed previously, go for an ultrasound, look for any pelvic pathologies. So that is ruled out. Then you have to have a neurologic examination because she is having frequency, urgency, nocturia. So there is a bladder overactivity. In the absence of infection, in the absence of some pelvic pathology, the next thing is to look at the neurologic causes. So neurologic causes have to be, if anything is there, it has to be addressed. So here we have to look at the duration of the symptoms. Like a short duration, you treat it symptomatically. If it's a prolonged, long duration symptomatology, the frequency, urgency, with lower abdominal discomfort, extending the, which is going to the extent of having the discomfort, going to the extent of having pain, with urgency, without incontinence. So
would you probably brand this as an overactive bladder, or?
Yeah, that's the point I'm coming at. So you're ruling out all the infective causes and other pathologies, you're ruling out neurology issues, and still everything is negative, and patient is having these symptoms like the frequency, urgency, urge incontinence, and maybe with or without pain. So where we classify it as overactive bladder, and in which scenario you have to go for further evaluations. Evaluation in the sense, evaluations to rule out any organic reasons for these things, the reasons which we discussed previously.
Would you think of any medications in her?
No, before medication, we have to go for further investigations, like in the sense of urodynamic test. Urodynamic test, where, basically, when you have all these storage symptoms, it is because of the bladder overactivity. So we have to make sure that we have to assess what is the severity of the bladder overactivity level, and what is, so when you have urinary incontinence, basically either it could be because of detrusor overactivity, or it could be because of the sphincter muscle inefficiency, like the bladder sphincter inefficiency. So we have to differentiate between these two things. You can differentiate with the history. Also, we can differentiate based on a urodynamic study, where you study the efficiency of the detrusors, whether there is any overactivity of the detrusor muscles, what is the efficiency of the sphincter muscles, whether there is any defect. Normally, we in a urinary cycle, we have two phases. One is the storage phase, and second is the voiding phase. So during storage phase, the detrusor muscles relax, and at the same time, the sphincter muscles contract. So this facilitates the urine coming and getting stored in the bladder. So up to the capacity, up to maybe 500. More than that, that is abnormal. So we assess that. So during the storage phase, we look for whether there is any detrusor overactivity that is happening, or whether there is any insufficiency of the sphincter. So these two things we can differentiate with the help of a urodynamic study. And again, we can quantify what is the severity of the detrusor overactivity during the storage phase. So based on these findings, we can
decide on which medication
approach,
is
about the pharmacologic management and other management options.
Okay. Now that we have dealt in detail with the medicines, the history, how we look at it, what are the surgical options, we will also invite our neurosurgeon to give us the latest techniques with regards to other newer modalities, and I hope to take the questions once Nihal has presented all the other options. Thank you. Do you want to ask any questions directly to the panel before we get into sacral nerve stimulations?
Sir? Overflow incontinence.
Overflowing
Yes.
incontinence. Can it happen without BPH and exclusively because of detrusor weakness or sphincter weakness?
Definitely.
And what is the, and what do you, how you, when you say the bladder is overactive?
Yes, sir. Basically, overflow incontinence means the bladder capacity is increased beyond this normal level, which can be either because of an obstruction or because of a detrusor failure. So, for the urine to be pumped out, one, the motor mechanism has to be active. The motor mechanism, it is being carried out by the detrusor muscles. So the detrusor muscle contracts, that builds up pressure inside the bladder and pushes the urine outside. So if the detrusor muscle is not functional properly, it is not functioning properly, there is any defect there, in which condition, which we call as detrusor hypoactivity. So in such situations, the pumping mechanism is failed, the pressure is not built up, the bladder gets over distended over a time. So normally the bladder capacity is 500 ml, but over a time, when the detrusor fails, the bladder wall is compliant, so it tries to accommodate more urine, and at a point, it fails to accommodate further urine and it overflows. That is how the overflow incontinence happens. So detrusor muscle failure can precipitate overflow incontinence. Again, in case of bladder outlet obstruction, So in the initial phase, it won't have the overflow incontinence, but if it becomes a chronic situation, like chronic bladder outlet obstruction, that leads on to this detrusor muscle failure and results in overflow incontinence. So per se, it can be because of some neurology problem where there is no outlet obstruction, or it can be secondary to outlet obstruction because of a chronic bladder outlet obstruction with some decompensation of the detrusor muscle leading on to detrusor hypoactivity and overflow incontinence. So in any case of overflow incontinence, we have to do a urodynamic study. That is in the guideline. We have to do a urodynamic study and differentiate. Whether there is a urodynamic study will help us to know whether there is detrusor hypoactivity. It will help us to know whether there is bladder outlet obstruction. So we will be able to differentiate between these two things or whether both of them are happening together. And based on that, we'll be able to plan the management.
What is the usual medicine you give for detrusor weakness?
Detrusor weakness. Generally, we give methanicol. Methanicol, we give 25 milligram BD or TID. That is the drug we give for detrusor hypoactivity.
Sachin, the last case, high-end IT professional lady, 30 year olds. I can't try some antidepressants, anti-anxiety measures after excluding UTA before going for the elaborate investigations.
So, sir, see, in such situations, you can try. You can go for non-invasive therapies. But as per the guidelines, see, she has got all the symptoms: frequency, urgency, nocturia, and pain. So when there is frequency, so you can go for a bladder diary and see whether she is mimicking or she is actually having a problem. We can assess the fluid intake and we can assess how much urine she is passing. So if she is mimicking, then we will be able to make out from the frequency voiding chart. If that is the case, you can go for what you are suggesting. You can go for that. If not, you have to go by the guidelines. The next step is to go for a urodynamics. If she's having a frank symptom, you have to go for a urodynamics and make sure. And urodynamics will definitely tell us whether there is any detrusor overactivity is there or not. It will definitely tell us.
Good evening, sirs and madam. I'm Dr. Nihal Ahmed. I'm a functional neurosurgeon in the Medical Trust Hospital. I've done my neurosurgery fellowship from the AIMS New Delhi in neuromodulation and fellowship in neuromodulation from Germany. So you must be wondering what a neurosurgeon is doing here in the amongst all the talk about urinary incontinence. So I just want to give you a brief overview about a newer modality, a breakthrough in the management of urinary incontinence that is called as sacral nerve stimulation. So sacral nerve stimulation is a recent, it was actually developed in 1982, but it was FDA approved in 1997. And it is for the same, like the last case what we mentioned, overactive bladder, that is one of the very good indications, along with fecal incontinence also. So what is this sacral nerve stimulation? So before going to that, we just, this diagram was already discussed. So we have three, I just want to give you a basic physiology. So there are three centers. We have the sacral micturition center in the S2, S4, that is the Onuf's, also called the Onuf's nucleus, which is a reflex center in which the parasympathetic and sympathetic impulses to the bladder cause a bladder contraction. And there is a pontine center, which is responsible for coordinating the relaxation. And there is the final higher center, the cerebral cortex, which mainly controls your voluntary desire for micturition, depending on the social situation. So if you come to involuntary control, you have parasympathetic and sympathetic, the S2 and S4. These act via cholinergic contract the detrusor in the muscarinic receptors M2, M3. So anticholinergics like oxybutynin and tolterodine, they can be used for overactive bladder, whereas cholinergic agonists like what we told, betanicol, can be used for non-obstructive urinary retention due to detrusor hypoactivity. And then we have sympathetic control, that is controlled by hypogastric nerves. Beta 2 and beta 3, they relax the detrusor, and alpha 1, sorry, I have written A1, alpha 1, which constricts the internal sphincter. So medical treatments with beta 3 sympathetic agonists like mirabegron and vibegron, they effectively address the symptoms of urinary urgency and overactivity without inducing the anticholinergic adverse effects. And of course, we have a voluntary control. Voluntary control is due to the S2, S4, the higher control, where we control the external sphincter. So the pudendal and the hypogastric nerves, they receive the sensory input from the bladder, and they transmit it to the higher centers, urethra, and to the brain, to the spinal cord, to the brain via the Onuf's nucleus. So there is something called the guarding reflex, which prevents the accidental leakage caused by sudden increase in the pressure, bladder pressure, which is called as a stress incontinence. So when bladder pressure abruptly rises, such as during coughing, sneezing, standing, the excitatory afferent fibers stimulate the Onuf's nucleus, which is in the S2, S4, which to activate the efferent fibers, leading to the contraction of the external sphincter, which prevents the leakage. This is the guarding reflex. So the mechanism of action, coming to the mechanism of SNS, it is still under debate. It is not exactly clear, but there are very there are multiple theories. So basically it modulates the spinal cord reflexes, and it is not direct stimulation of the bladder or the sphincter. It is through the afferents, the afferent signaling pathway, the afferent nerves, those are the pudendal nerves. So that it interrupts. So various theories are there, like in the younger patient, the neurological case, like if you have multiple sclerosis or other spinal tube defects, so there are C fiber activity. So sacral neuromodulation blocks this C fiber hyperactivity. So and also I mentioned about guarding reflex. So guarding reflex, it inhibits the guarding reflex. So it relaxes, it stimulates the relaxation of pelvic floor muscles. So in postpartum females, this mechanism can be useful. And also it has a higher center, Brodmann area 9, which also controls, helps in better control of the urine. So also we have for fecal incontinence, urinary incontinence and fecal incontinence both go hand in hand together. So which are the patients who are eligible? So patients, they should have urinary incontinence, they should have refractory non-obstructive urinary retention, and they should have failed to respond to the behavioral modifications and pharmacotherapy despite undergoing more than one medical therapy for a duration of at least 8 to 12 weeks. So individuals are obviously they will be maintaining a voiding diary to track the urinary and fecal symptoms and establish a baseline, and this diary should be updated throughout the clinical trial to evaluate any improvement. And what is called improvement? Improvement is reduction in symptoms, or in 50% reduction of the symptoms is called improvement in sacral nerve stimulation. So what are not a good candidates? Those are which have, obviously I told non-obstructive. So obstruction, any obstruction like the first case what we mentioned, the BPH, it is not a good indication. If there are recurrent pelvic infections, So obviously we are putting an implant. So infection is not a, and age is not a barrier. Patients older than 55 years, up to 55 years can be, can undergo sacral nerve stimulation. So what is sacral nerve stimulation? How it is done? But I will not go into the details, but basically it is, we are targeting the sacral nerve at the S3 foramen. So we do this procedure with the patient awake and with local anesthesia, and there are two phases of this. So there is a trial phase and there is a permanent phase. So we assess how much response the patient has in the trial phase. So basically what we look for is a S3 nerve. So we have to put the lead in the sacral S3 foramen and we assess for the toe flexion. So that helps us to locate the exact site of the lead insertion. So these are all the materials which are involved, and we have steps to delineate where exactly we put the leads. So at the exit foramen, so we track the nerve from medial to lateral and we go along the nerve and put the sacral nerve leads. So this is what, and the lead is connected to a battery. A battery is implanted in the gluteal region, and then we do the patient programming. So this is the area of area at how we do. And this is the lead. This is how it looks on a X-ray. The lead placement at the S3 foramen. And once the lead is positioned, we tunnel it, and then the battery is implanted after a successful lead, after a successful trial. So this is the interstim, Medtronic interstim battery, which goes and which these are some of the images. I don't want to go into much detail. So this battery can be, once the patient notes reduction in the symptoms, like 50% reduction of symptoms, and once, so the trial phase is successful, then we replace the trial battery with the permanent battery and we implant it into the gluteal region. So this is the symptom relief. So similar to the voiding diary, we maintain a diary and we assess the response and a quality of life assessment. So this is the programmer, the wireless programmer, what we do, and we do a programming. There are some specific programming parameters, frequency, amplitude. Slowly we start with the lower frequency and then increase. So this is, there are 4 leads, as you can see, which are targeting the sacral nerve. So that was about the procedure. So I'll just talk about the outcomes. What are the outcomes? Various studies which I have done. So there is a meta-analysis of this sacral nerve stimulation with 4 RCTs and 30 case series, and 120 patients in the RCTs showed that 80% of the cases have achieved more than 50%. So 50% improvement in symptoms is considered as successful. So that 80% of them have achieved that. Whereas in the case series, 67% have achieved that, and the benefit will persist up to 5 years of the surgery. Even the battery life, what we have, the current battery life is also for 5 years. So it's a relatively safe procedure. So the pain will be there initially, which is most common side effect, but it will reduce over a period of time. Then there are lead migration and IPG migration. The lead migrate, which is 15%, which is a little higher, but because of newer technology, now the lead migration rates have come down. Other infection may be one of the side effects. So we have 5-year follow-up prospective multicentric study for overactive bladder, so in which the success rate was ranging from 67 to 82%. And there is other modality called the botulinum toxin for overactive bladder, which is compared with SNS, sacral nerve stimulation, in the Rosetta trial. So we inject cystoscopically 200 international units of botulinum toxin. So for 6 months the effect will be, it is actually when compared to SNS, that had a slightly better outcome, but the patient needs to be on regular follow-up, and then there is higher risk of urinary tract infection, and always there is a risk of urinary retentions, and so that is the patient may have to go for transient self-catheterization. So these are the problems with botulinum toxin. Even in fecal incontinence, 86% of the patients had more than 50% improvement in fecal incontinence symptoms, and perfect continence was achieved in 40% of the cases. So sacral nerve stimulation is a neuromodulation tool, FDA approved for symptoms of overactive bladder predominantly, especially urge incontinence, and also as well as it works very well in fecal incontinence too. So patient selection is most important, and you can always give them a trial, and younger patients tend to benefit the most, and only the patients who show good response to the trial phase, they should get a permanent implant. And it's a very minimally invasive procedure. It's no need of general anesthesia, and it can be done with very few side effects, and success of the procedure very much depends on the correct lead placement. And excellent results, as you can see, I have given you the outcomes. They have been observed in well selected cases with significant improvement in quality of life. So that is all I want to tell about sacral nerve.
Thank you. We have time for just one question. Anyone?
In AIMS Delhi, we have done three to four cases. AIMS.
In medical test?
No, not yet.
So I think since the time is late, we will take questions during dinner time. The faculty will be here. So on behalf of GPA and Medical Trust Hospital, I'd like to thank the speakers and the panelists. Can we have a nice round of applause? So what they have actually done is, taught us how to manage a very common problem which is usually very under discussed. And this again makes this not only informative, but also it's very a lot of impact on our clinical practice as well. So with that, I'll invite our office bearers onto stage. And thank you once again, Dr. Nihal.
We had an elaborate discussion on urinary incontinence and as well as a wonderful talk on sacral nerve stimulation. Hope all you have enlightened on the topics. Now I invite our secretary for association matters and vote of thanks.
Good evening once again. I think all of us had an enlightening session on the topics. Day-to-day life, almost all of us